this special session for Sydney Vital. It's not often Sydney Vital's had a physicist coming to speak at it, so that's a really pleasure. It's a great pleasure to welcome Thomas here as well from Boston. Thomas is German, but he's been in the US for a very long time. He started the German Cancer Research Centre, which has been really important in the last 10 years or so for nuclear medicine, because that's been the place that all the new peptides are coming out of. That's really revolutionised radionuclide therapy. So it's got an illustrious history. And from there, he went to MD Anderson and then on to Harvard, where he set up early the multi-leaf collimator-based IMRT systems. He eventually found himself in Boston at Harvard Medical School, where he's professor and chief of the radiation physics, biophysics division at MGH. He's going to tell us a bit today about spatial temporal optimization of radiation therapy, and I think it's really appropriate because physicists have been fascinated by space and time questions from Galileo, Newton, Einstein, Stephen Hawking, and so Thomas is continuing a great tradition there of talking about space and time to us today in radiotherapy. So Thomas, welcome. It's great to have you here, and we'll just mic you up.
Thanks so much, Dave, for the nice introduction. So you're setting the expectations very high here with Galilei, and so I'll do my best. So usually these days I talk a lot about proton therapy, but today I decided to not talk about protons at all, but about some of my other research pet projects. And I called it the Grand Challenges in Temporo-spatial Optimization, which is a mouthful of like a title, but I'll be very sort of I'll address three main challenges that we are facing in our field. The first challenge is with all the precision that we now achieved in terms of aiming radiation at tumors. The challenge really becomes, what is the tumor that we want to treat? So we can treat essentially anything in the patient, but what is the clinical target for him that needs to be treated, especially in the context of developments in immunotherapy and combinations of immunotherapy and radiation therapy and targeted therapy modalities. So that's going to be my first topic. Let's start with that. Oh, I think I can use the advance here. Doesn't seem to work. Yeah, and the battery, is it the one, right? Yeah. Oh. I can just use the arrows then. It works? Yeah. Okay, let me first thank the Harvard Club of Australia for supporting my trip here. So I've been in Australia for 2 weeks now. I spent 2 weeks in Perth, went to the physics meeting there and spent a week with the physics group in Perth. And then I arrived here in Sydney on Saturday, and I'm going to be here for another week, spending some time here and some time in Wollongong. So the first topic is transforming the CTV definition from an art to a science. Like I said, with all the precision that we are now achieving in terms of targeting radiation, the challenge becomes, what is the area that we actually want to treat? And I'll focus on glioblastoma here, but I mean, similar concepts apply to many other diseases. And so the problem is shown here. We have a visible tumor. Usually we use MRI imaging, either T1 post-contrast as shown here, or T2 FLAIR imaging, which shows both the primary tumor and the edema. And that's the starting point of our treatment design, treatment planning process. What we don't see, of course, is the tumor extent beyond the visible region that is seen on the MRI image. And I'm working with nuclear medicine at MGH in Boston, and I keep telling them, you know, why can't we make the microscopic disease visible? And I'm not sure if you have any answers to that challenge, but it is. I mean, if we could actually see the extent of the tumor beyond what we see, say, in MRI or CT imaging, that would be an enormous advantage. But we just don't have the, I guess, the resolution, but also sort of the dynamic contrast that is needed to detect groups of cells, maybe a few hundred cells or so, infiltrating the normal tissue surrounding the primary tumor. So we have to rely on models and on assumptions that are based on the clinical experience of treating the patients. So of course, in biopsies, we have seen tumor away, like centimeters or even further away from the primary tumor. We did immunohistochemical analyses and found tumor essentially in the case of glioblastoma anywhere in the brain, far away from the primary tumor in those spots here. And we also did mathematical studies, mathematical models to model the spread of the tumor through the normal tissue by describing it, the process as a diffusion equation, which is a mathematical formulation. And then we calculated the likelihood or probability of finding tumor cells anywhere in the brain, even far away from the primary target. So this is sort of the state of the knowledge and the state of the art in the field. What we do clinically is very simplistic. So in the past, we used whole brain irradiation, and we reduced the fields to partial brain irradiation. And today, the state of the art is to define the target based on the post-operative MRI. There are different guidelines in Europe and in America. I don't know which of these guidelines, or maybe we have different guidelines in Australia, but essentially the European guideline is to treat 60 grade to the T1 weighted MRI scans and add a 2 centimeter margin around that. In the US, the guideline is to treat a larger area that includes the T2 weighted MRI flare image, 2 centimeter margin around that, treated at 46 gray, and 60 gray boost to the T1 weighted area with a 2 centimeter margin as well. So different groups use different guidelines, but generally speaking, it's a very simplistic way to define the targets. So here we have a European ASTRO-ACROP guideline for targeting of glioblastoma that published these recommendations. And essentially what they tell you is that you contour the gross tumor volume, expand it by 2 centimeter, and then you trim the expansion by barrier structures that are serving as natural boundaries to the spread of the disease. Okay, here we have this demonstration of this approach. So we manually contour the gross tumor volume. We expand it by 2 centimeters, but we trim it near those areas here. This is the falx cerebri, so the midline through the brain. And then, of course, we also trim it at the skull. And then we use this as our clinical target volume as the sort of starting point for our treatment planning. So what are the problems with this current approach? There are several problems. One is it is a very time-consuming manual process. It takes up to 5 hours for our clinicians to manually draw all these structures and then to trim them. The challenge with the trimming is not only to determine which organs serve as barrier structures, but then how to define these expansions in 3 dimensions. Because you can easily imagine that the tumor grows. Let's look at this example, for example. it's not only spread in this 2D plane, but it's the spread in 3 dimensions that has to be taken into account somehow, and that's very hard to do manually. So it takes a lot of time. There's a lack of precision because of the challenge of the human brain to determine margin expansions in 3 dimensions. There's a lot of large intercondition variability, and there's really no ground truth. If you ask different physicians to do the contouring, even based on these guidelines, you get very different answers. So here we have a study recently published where they asked 10 clinicians to do this exercise for a number of patients, and you see essentially 10 different answers. So then it really becomes questionable whether we should put much more physics work into targeting with a 1 millimeter precision, given that now the variations of these contours are several centimeters or more. So the question is, what can we do about that? And we propose a pragmatic solution to this problem for now, which is inspired by the clinical guidelines. So the hypothesis is that it's difficult to determine the exact spread of the disease because of the lack of imaging capabilities. But the barrier structures that serve as barriers to the spread are relatively easy to determine. So the idea is that we do an auto-segmentation of the barrier structures and then expand the cross-tumor volume by the standard margin of 2 centimeters for this consideration of the barrier structures. So this is what we now implemented in RayStation, actually, which is our planning system. So here we have the manual segmentation of the different barrier structures, including the ventricles, the falx, the cerebellum, and others. And here's the auto segmentation of the same structures. And with machine learning based approaches, which we use in this case, this is a UNet, which is standard method in machine learning these days for segmentation. Those machine learning methods have become so powerful that it is a relatively straightforward problem to segment these well-defined barrier structures. Here we have for 40 patients the different structures that we use, and the surface dice coefficient, which is high, which means that there's a very good agreement between the manually segmented structures and the automated structures. Okay, then the second step, after we have those anatomical structures defined automatically, the second step is to determine the expansion of 2 centimeters in 3 dimensions. And there's been quite a bit of work years ago. This is from a group from France, I believe, that looked at this problem and solved it with computers, limited computer power at the time. Today we have, of course, faster computers and more advanced methods. So the way we solve this problem is in the following way. Say we have a target volume here in this artificial scenario. This is our target structure, and we want to determine the distance of this voxel from the target, right? What we do is we use the so-called Dijkstra algorithm to determine the shortest path of this voxel from the target volume. And this is, say, a barrier structure. So there's no path of the spreading tumor through this area, which could be the falx cerebri, for example. And so the tumor has to grow around the structure and to reach this point. So then we can also define different resistances to the spread in different structures. So in this case, we define the higher resistance to spread in this area. So that tells you that the most likely path is on the other side around this barrier structure. So the shortest path becomes longer because it's there's more resistance in this on this side here. So this is a very simplistic way to determine the expansion in 3 dimensions. Or this is only 2 dimensions, but you can. It's obvious how to expand it into 3 dimensions. And we can not only consider barrier structures as one shown here, but differences in terms of resistance to the spread, high resistance on this side and low resistance there. So that's the computer model. Here's the result for a clinical case. Now this is the gross tumor volume shown in red. And here we see different distances calculated with this method from the gross tumor volume, shown with different colors. So typically we look at 2 centimeters, which is this bluish region here, I guess. So that would be here. Okay, that would be the normal marginal expansion, but we can now in the planning system we can now play with variable margins and see the real trade-off between covering more target with smaller probabilities of infiltration and the price that we pay for this in terms of delivering more dose to the surrounding critical structures. What you see in this example is that the automated structure that was drawn by the clinician, many hours of manual work, agrees very well actually with the automated structure. So this saves time and hopefully will produce more consistent results in the contouring of target volumes in the future. Here we have another example, same message. So there's pretty good agreement between the manual contour and the automated contour, and it respects all these barrier structures and different brain tissues surrounding the tumor. So what we can also do with this method, as I already mentioned, is we can now in the planning system, we can set a threshold on the mean brain dose, and depending on the mean brain dose, we can vary the expansion around the gross tumor volume, and then if we allow higher mean brain dose of say close to 50 gray as shown here, then we get a better coverage of even lower probability infiltration of the tumor. If we restrict the dose to the healthy brain to 30 gray or less, then we get a more limited expansion. But the physician at the time of treatment planning can now make this decision interactively and apply their clinical judgment in a more controlled and well-defined way than what is currently possible. So this is one area. I mean, this is just one very simple example, but I believe that this is an area that we need to work on to make the next quantum leap in treatment success, namely by being more consistent in prescribing our targets and then defining them in a more consistent way between the different hospitals and even between the different physicians in the same hospital. Because if you were asked different physicians, like I said, to draw the target volumes, you get very different answers. Even when you ask the same physician on different days, they will have slightly different opinions when you ask them again tomorrow. Okay, so any questions about this first topic before I move on to the next? Okay. So the second grand challenge that I see in treatment, in radiation treatment, is the question of optimal stopping. That's our definition of this problem. We just started to work on this, and I will describe this in a little bit more detail. So the idea is that normally today we treat every patient, not every patient, but most patients with the same type of tumor with the same radiation dose, right? And even though we shape the field, we shape the dose based on the shape of the tumor that we see in, say, the CT, MRI, and PET images, we give the same radiation dose, more or less. And the next evolution step in radiation therapy has to be that we personalize not only the shape of the radiation dose, but also the dose level. So we should give more dose to patients who are, more tolerant, so that we can actually get a higher likelihood of tumor control in those patients, and we should give less dose to patients who are more sensitive. So that idea of personalizing treatment is, I'll discuss in my second topic here. The importance of patient-specific information has been described many times, and this is from a paper we published now 3 years ago. There has been very much progress in radiation therapy from the 1980s until today. This is for head and neck cancers, and local regional control has been increased from like about 1/3, less than 30% actually, to more than 80% in more recent years. And this has been thanks to a number of advances, hypoxic modifications, accelerated fractionation, different fractionation schemes, and the combination of radiation with chemotherapy. Now, the next advance is expected to come from more personalization, in the sense that we know, for example, for head and neck cancer, that there's a different response for HPV positive patients versus HPV negative patients. Still, today, we give them all more or less the same dose. Now, there's very few clinics who look into dose escalation or dose de-escalation based on their HPV status. One is Sloan Kettering Cancer Center in New York. One is the University of, several universities in Germany, actually. But by and large, we treat them with the same dose. So this has to change. So we have to include that sort of biological information about the patient's inherent sensitivity in the planning process and give them different dose levels. But we should take this to the next level and do it not only based on information we collect before the treatment starts, but the response of the patient during the treatment. And this is what we aim at with the idea of optimal stopping, which we've started to work on in an international collaboration a couple of years ago. And we have this publication that describes the idea published in the Green Journal last year. So the motivation is shown here. If you do patient stratification, say based on the HPV status, you would expect that some patients are more radiosensitive, others are less radiosensitive. And of course, there's some variation, but if you have these two groups, then you should give these two groups two different dose levels, which is being done now in the dose escalation and dose de-escalation trials. But the next step should be that we do this even more personalized by measuring the response of the patient, and then say after giving that much of dose, say 50 gray, let's say this is 50 gray here, then we assess the expected probability of that patient developing complications versus the expectation for that specific patient to control the tumor in that patient. And that may be different from what we expect based on what we know from before the treatment started. So by collecting information during the treatment, we then know whether this patient is on this curve or on that curve, you know, or on this curve or on that curve. And based on that information, we change the dose level dynamically during the course of the treatment. That's sort of the promise here. So we tested this idea first based on a lung trial that we ran between the MGH, where I'm working, and the MD Anderson Cancer Center. We have a limited number of patients here, so this is just a pilot study, really. But what we know from past experiences that in this case, the risk of developing radiation pneumonitis as a side effect of the treatment depends on the dose level given, but it also depends on the individual sensitivity of the patient. Some patients are more resistant and other patients are more sensitive. So for the same dose level of, say, 70 gray, if you look at the FDG SUV in different parts of the lung, in this case, then for some patients you get a more shallow dependence, and for other patients you get a steeper slope here. Okay, so that tells you ultimately what the risk of developing radiation pneumonitis is after the treatment has been completed. So the question is, can we learn about the individual patient sensitivity during the course of the treatment before the treatment has been completed? So we look at this midterm, in the halfway through the treatment after delivering like half of the dose of 35 gray. And here, again, it turns out that this characteristic, the personal sensitivity of the patient, is already showing up after delivering not 70 gray, but 35 gray. So that means that for those patients where we have a higher SUV uptake, we can then maybe adjust the dose to take into account that they have a higher risk of developing this side effect. Okay, so this is what we did. And so we have those parameters, say the SUV FDG PET image taken during and after the treatment was completed, and also other features such as radiomics features from the CT and from the PET imaging. Then we developed a random forest approach to classify the patients into those RP positive or RP negative classes, and also a Bayesian network approach, which is another way to describe these phenomena on a more probabilistic level. And I don't have the time to describe that in more detail. Some technicalities here that I'll skip. But so the random forest method was used to select the variables that are most important for, the outcome in terms of RP plus, RP minus. And the biggest importance is the SUV versus dose slope that I showed in the previous figure. So whether the patients show a high uptake of FDG in the lung for a given dose level, or a smaller uptake of FDG. But there are other parameters that are also shown here and that also have some significance. So then we start with this random tree approach and then develop that into a Bayesian network model that gives us the outcome, the expected outcome for radiation pneumonitis based on these individual parameters, right? And all these links here are related to probabilities that link this feature to the risk of developing radiation pneumonitis. And the idea is that we can present this to the treating physician probably in a somewhat simpler way, but they can then check what's happening with this patient after like 10 days of treatment or so, and then make the decision whether we should, give them more dose or whether we should rather stop the treatment at this point because the risk of developing side effects is becoming too high. So 2 take-home messages from this study here. Technically, it turned out that the combination of the random forest and the Bayesian network is a very promising approach, because with the standalone Bayesian network, we get an area under the curve of 0.72. Standalone random forest is even a little bit smaller, but the 2 combined give a pretty good area under the curve of 0.84. So that is a promising method and a promising way forward. Second take-home message is that the importance of mid-treatment information. That goes back to what I said at the beginning. So what we want to do is we want to take information not only taken before the treatment starts, but we want to dynamically assess the patient's status during the treatment, and then make decisions sort of on the fly to determine the optimal dose level for that patient, right? So several future steps that we will take now. We'll validate this on a larger cohort of patients. So far we looked at the normal tissue only, but now we're extending this to tumor response. Build dynamic TCP and NTCP models. TCP is tumor control, NTCP is normal tissue complication probability. So we are developing these models not only for the total dose delivered during the whole course of treatment, but dynamically as we deliver the dose fraction by fraction. And then include other information such as the weekly 40-CT, blood-based biomarkers, and patient-reported outcome, which is becoming more and more important in our field. Okay, so that's the second part of my lecture. So the second grand challenge. The first was, how do we determine what we actually want to treat? The second part is, how can we individualize the dose level for patients, give different dose levels based on their individual sensitivity to radiation. The bigger picture then is that we will allow this optimal stopping to also include multimodality treatments, such as combination of radiation, targeted therapies, immunotherapies, based on similar concepts here, decide during the course of the treatment how much of these different modalities should we give to the patient, and when, and then maybe switch when we don't see the expected response, switch to another type of treatment. The last part of my talk is a few brief words about flash therapy. So you may have heard about flash therapy, which is the idea to treat not human patients yet, with one exception, but cells and mice in a very short time with, say, 40, 50 gray per second. And what has been shown is that if we treat with a high dose rate of, say, 3,600 gray per minute, in the case of pulmonary fibrosis as the side effect, we get a much smaller risk of developing pulmonary fibrosis compared to the standard treatment rate of 1.8 gray per minute. So this gives the same dose, looks at different times after the irradiation, and you see this big difference in terms of the response. This finding has triggered a lot of research work recently. There has been a special issue of the Radiotherapy and Oncology journal just published last month, on flash radiotherapy. So this is becoming a really, really big topic in our field. There's been a counterpoint discussion in the Medical Physics Journal a few months back in the summer between Peter Maxim and Paul Kiel. And there's even today that there are like some groups that develop or design, let's say, new treatment machines that will allow a radiation dose to be delivered quasi-simultaneously from different directions of incidence to utilize this flash effect. You know, because the if you have to deliver 40, 50 gray in 1 second, you cannot do that with different beams coming, you know, like with 1 minute or more apart. So you have to give it all at the same time. So people are already thinking about the design of futuristic treatment machines based on these ideas. But I would caution you against the being maybe too optimistic about the possibilities of flash therapy. First of all, there have been biological experiments done in the 1950s, 60s, and 70s on that same effect, and this I find quite fascinating. So this is from a publication from 1974, where they did not treat cancer cells, but E. coli bacteria, but they show this very striking effect. So depending on the dose, which is here in K-rats, so 10 is very high doses actually. So 10 is 100 gray, right? 200 gray, and so very high doses. But what they show is that there's this kink in the survival curve, and the position of the kink depends on the oxygenation. So with lower oxygenation, the kink appears at lower doses. So that is more hypoxic tissues or cells. With better oxygenation, the kink appears later. So the biological or radiochemical explanation of this is that the radiation dose delivered sort of depletes the oxygen in the tissues, and after the oxygen has been depleted, we get only the direct cell kill effect, the direct interaction of the radiation with the DNA, and then the effect becomes smaller after the oxygen has been all depleted. So first, a steeper slope with oxygen, and then once the oxygen has been used up, more shallow. Steeper effect with the oxygen, and then once it's all gone, then we have a more shallow survival curve. So the clinical promise here is that we can protect normal tissues in this way, because normal tissues are normally more oxygenated than tumor tissue. So in tumor tissue, we usually have a hypoxic situation, low oxygen levels, and so for tumors, the flash effect makes no difference. But in normal tissues with better oxygenation, it does make a difference whether we treat with very high dose rates or small dose rates, and that has been shown in some of the recent studies as well. But like I said, we have to keep in mind the price of flash, and the price is very high. So essentially, we have to give up everything that has led to the success of radiotherapy over the past decades, namely the idea of fractionation. So we treat patients not with high dose at one time, but we usually fractionate, even though today we move towards SBRT type of treatments with higher dose per fraction. But the flash effect probably requires, as far as we know today, doses per fraction of 8 gray, 10 gray or higher. So we cannot really use fractionation in the same way that we use it in conventional treatments. Secondly, we normally use multi-field treatments, obviously, right? Multiple beams. This becomes a big problem with flash unless we use this phaser idea that was shown in the previous slide. But this requires completely new technical developments that are not available yet. And then we probably also have to give up IMRT. So with IMRT, as you know, we treat the fields with a multi-leaf collimator dynamically moving over the field. That whole idea will go and will not be possible if we want to use the flash effect. So there's a lot of expectation, but the price may be very high, and it needs to be seen, I think, first from biological studies what the real effect is before we move on to building new machines that exploit this effect. And secondly, we need to understand better why this effect hasn't been exploited earlier, because there were all these people who worked on this experiments in the 1960s, 1970s, and then somehow the effect has been forgotten and sort of been reactivated about 5 years ago. So the question is, why did people 40 years ago not continue to work on this and push it into the clinic? So it will be very important to understand this better.